Hi everyone, welcome to our SRHT Project Health webinar, Reaching Financial Success in the Transition to Value. My name is Shannon Greeley and I will be hosting today's Small Rural Hospital Transition Project Health webinar. You may communicate via the text box at any time. We will go over any questions at the end of the call. Feel free to send me any private chat at any time too by hovering over my name in the attendee list. I'm showing up as Kim Norden, so go ahead and do a private chat to Kim and we will get that question answered at the end. The slides for this presentation can be downloaded by clicking on the file share or can be found on the playback page for this webinar. After the presentation, I will provide you with a link to our short online assessment. If you would like one, ACHE Qualified Education Credit and Certificate, an assessment must be completed. I already went ahead and started the recording, so we'll get started in just a moment here. And again, if you have any questions, either type them into the chat box, press *2 to unmute your line, or send Kim Norden a private question by hovering over her name at the top of the attendee list. I'll now turn it over to Sally Buck.
Thank you, Shannon. Welcome everyone to the 2018 Rural Hospital and Clinic Financial Summit Report Health webinar. And today I will be joined by Terry Hill, our Senior Advisor for Rural Health Policy and Leadership and Executive Director of Rural Health Innovations to present, and a few of our summit participants. And this webinar is hosted by the National Rural Health Resource Center and Rural Health Innovations, who are the provider for the Small Rural Hospital Transition Project. And Rural Health Innovations, LLC, is a subsidiary of the National Rural Health Resource Center. And together, RHI and the Center, the nation's leading technical assistance and knowledge centers in rural health. And in partnership with the Center, RHI connects rural health organizations with innovations that enhance the health of rural communities. RHI is the contract for the Small Rural Hospital Transitions Consultations Project, and we are in the fourth year of that contract. And the center has a cooperative agreement for information services for small rural hospitals, and the education and outreach for SRHT, as well as the Small Rural Hospital Improvement Program and the Medicare Rural Hospital Flexibility Program are also within that cooperative agreement. Today we're going to present the findings from the 2018 Financial Summit and key in on the process that we looked at, the 2012 key performance indicators, and then the process and actual indicators and strategies that were revealed from the summit. Also, Terry will review the Critical Access Hospital Finance 101 manual updates and the expansion, which has given it a new change, and we'll discuss some strategies and best practices with two participants from the summit, and also share some resources that are key from the summit findings. And this project, the Small Rural Hospital Transitions Project, is supported by the Federal Office of Rural Health Policy within the Department of Health and Human Services, and SRHT, as it's known for short, provides on-site technical assistance to 9 selected hospitals annually through an application and selection process. And these hospitals receive on-site technical assistance for either a financial operational assessment or quality improvement project. And SRHT, the goals of SRHT are to help hospitals bridge the gap between the current volume-based healthcare system, especially at critical access hospitals, rural health clinics, and community health centers, which are under still fee-for-service volume-based system, and the newly emerging value-based system of healthcare delivery and payment. And the project provides TA through those on-site consultations and also disseminates best practices and strategies to rural hospital and network leaders. The 2018 Financial Summit was convened in May 2018, and this was supported through our cooperative agreement for SHRT with the Federal Office of Rural Health Policy. And the purpose was to identify the most important financial indicators and strategies to transition to value-based payments. And the findings are designed to help both rural hospitals and rural health clinic leaders meet this transition with financial success. And this summit was building upon previous summits that looked at financial strategies and strategies to moving to value-based care and payment, as well as the summit we held back in 2012 specifically on finance that identified the top 10 key performance indicators. Our summit participants met in Bloomington, Minnesota over 2 days, and they included these participants from State Office of Rural Health, Plus Programs, Hospital Association, a Critical Access Hospital CEO, Network Director, who represents 40 small rural hospitals and is also a network development grantee, the Federal Office of Rural Health Policy, Flex Monitoring Team, Rural Health Value, and our SMEs from 3 different consulting groups that work primarily with small rural hospitals and clinics. We had a great group of field experts and representatives for the summit. I'll turn it over to Terry Hill, which will help frame up the summit and our findings.
Thank you very much, Sally. And as Sally mentioned, this was a follow-up to our 2012 meeting when, again, we brought in financial experts from across the country to help guide us in terms of identifying, which were the most important financial indicators. And because a lot has happened since that time, we now have a different payment model that is playing out across the country and playing out with our rural hospitals as well. So as you know, we're moving from the old system of financial payment into something called the value payment system. And about 10 years ago, the IHI kind of launched this triple aim, which really looked at providing better care, better health care overall for our population at lower cost. And we all know that the problems that were inherent in the previous system, it was basically pay per procedure. It was a lot of procedures being made, a lot of overproduction, a lot of unnecessary surgeries, et cetera. And the cost continued to rise to the sense that it really disadvantaged us in the international healthcare marketplace, but it also had devastating effects upon our people in this country, and healthcare costs are the leading cause of bankruptcy, et cetera. We all know, those sorts of statistics. And when we shifted in this new direction into value and population health. And again, as it's defined here, it's better care and smarter spending are going to result in healthier people. Now, one of the first things we did in the summit, and it was 2 half days, as Sally indicated, and we looked at the key financial indicators that had been identified in that 2012 summit. And those included days in accounts receivable, days cash on hand, total margin, operating margin, long-term debt to capitalization, debt service coverage, salaries to net patient revenue, Medicare inpatient payer mix, and average age of plant. And so the first question was, are these still relevant? Are they still extremely important? And we got a pretty resounding yes to that from our panel. They're still very important, and that absolutely, being as financially profitable as possible is almost a prerequisite for moving into the value and population health arena. So if we're in heavy financial debt, if our business office is suffering and we're simply not maximizing the efficiency in our business processes, if our numbers of these key financial indicators are low, then it's going to be very difficult for us moving forward, because we're going to have the capital, the money available to make investments into infrastructure, into technology, and into people and expertise as well. So we pretty much resolved to keep these indicators as being extremely important, and we then moved into another area. And the concept here is these are key indicators for rural hospital and clinics in value formation formulas. So there are a lot of measures that aren't historically thought of as financial. But the idea here is that these measures basically are correlated with positive financial performance in the value-based systems. And how do we know this? Basically, we now have a pretty extensive set of data and information about rural hospitals' performance, particularly in accountable care organizations. And in essence, the good news is that our rural hospitals have pretty dramatically outperformed urban hospitals when you look at any sort of a comparison. Our ACOs have been basically producing not only financial savings, but they've been able to, many of them have been able to get some of the bonuses that were promised in these accountable care organizations. And so as we looked at that, our summit participants identified what are these measurables then that were identified with solid and excellent financial performance in the value models. And we came up with measures that again qualify as what we call lead indicators. They are indicative of financial success in the value model. So the historic financial indicators are what we call lag indicators. In other words, they basically reflect what has gone on in terms of financial performance in the past. And these financial indicators, which now supplement the financial indicators that had been done historically, are indicators of our future success. So in this regard, we identified, these are the categories, and I'm going to go into a little more detail here in just a minute. There were market indicators that we classified, so we have several in that category. There were financial performance and conditions. There were indicators that corresponded to operational efficiency. We had some indicators that corresponded to workforce. Again, remember the formula now really rewards quality, so we felt that there were quality measures that need to be factored in here. There were care management, kind of care coordination indicators. And in a population health payment system, we felt community health was extremely important, and we need to be looking at measures there. And then finally, there was kind of a catch-all category which we classified as organizational attributes. So kind of these are things that have to do with your associations, perhaps with others, your membership in a system, or other things in that regard. So as we looked at that, the market indicators, market share was extremely important. What's going to happen is that in the value system, as days in hospital beds, the inpatient days goes down, it's really imperative to maximize market share, and particularly out-migration rates. And one of the aha moments I know for hospital leaders and ACOs, once they look at the data, is that our average rural hospital is not capturing all of the business that it might. In fact, a significant percentage, in many cases almost half of the potential business is leaving through out-migration, going to either other hospitals or bigger tertiary care centers, etc. So we felt that measuring those outpatient rates were extremely important, as well as market share. The number of attributed lives becomes incredibly important in an ACO model. Again, accountable care organizations are assigned a certain number of attributed lives, and knowing who those folks were and having those numbers continues to be very, very important. The number of unique patients was identified, and finally the level of integration as well. So those were 5 market indicators that our group felt should be looked at by any hospital considering moving into value. Now, one of the things I should say is we don't necessarily have benchmarks for all of these. To some degree, we're going to try to identify as many as we possibly can, but there was just absolutely no way to come up with definitive measures or even benchmarks for every one of these. But this is a starting point that we intend to build on as we move forward. Liquidity becomes another thing. So that one is a financial measure, pretty much the old historic measure, and that's a current ratio or average payment comes in here as well. And the liquidity ratio, for example, is how much money do we have available, how much cash is available to meet our short-term debts. If we have a really high liquidity ratio, and there's not one that's necessarily right, if we have a high liquidity ratio, it may mean that we've got too much cash and we're not investing enough. A very low liquidity ratio really puts us in a problem, just not being able to meet our short-term debts, or not being able to make investments in something that we think is going to be really important. Operational efficiency, again, if you're in an accountable care organization, I don't have to tell you this, but we start looking at costs here in efficiency. And again, to be successful, we have to really maximize our efficiency, our clinical efficiency, financial efficiency, et cetera. So we're looking for what is the average cost per clinic visit. So what's it costing us for these clinic visits? What are the productivity rates for primary care practitioners? And again, primary care practitioners are at the heart of this financial model, the value model. The assignment of covered lives, the attributed lives basically revolve around those primary care practitioners. So we've got to maximize our productivity rates, and we also need to look at establishing perhaps some minimum productivity requirements for rural health clinics. By the way, rural health clinics now becomes embedded in our new Financial 101 manual, or the old one has now been updated to include measures and include recommendations for rural health clinics. So we start here by looking specifically at those productivity requirements for those rural health clinics. Under workforce, again, we know that provider and staff engagement becomes extremely important, and towards the top of the priority list for our value-based models is the collaboration between our healthcare providers and our hospital leadership. So we want to identify how engaged are our physicians, for example, and do our staff actually understand what the change that is happening, and are they engaged? Do they understand the difference in payment? We're talking now about a really patient-centered sort of an approach, and we need everybody to be on board. And engagement is something that can be measured, and same thing with provider engagement. how many primary care practitioners are in the service area? How many folks do we have? Primary care practitioners are absolutely at a premium. We've always had a shortage, and it becomes absolutely essential that we keep those folks. They're one of our greatest assets, and we need to really put a focus on how many do we have, not just physicians, but nurse practitioners, PAs, et cetera, and we need to continue to monitor that. Staff satisfaction scores actually are very strongly correlated to patient satisfaction scores. And you know, it actually goes both ways. High patient satisfaction scores generally means high staff satisfaction scores, but something that seems not financially related at all really it needs to be factored in here as staff satisfaction related to patient satisfaction. And then we basically are going in the value formula, patient satisfaction gets calculated and is part of the formula for our reimbursement and for our bonuses. Primary care practitioner information, the suggestions from our group was retention rates to track turnover. Provider satisfaction scores, our folks really thought was crucial. We've got to know what our providers are thinking. We can't wait till they're dissatisfied or they leave. We've got to really figure out how can we keep them, how can we monitor their satisfaction, and basically how do we engage them. And then looking at the new market growth rates as well. So we've got new markets coming in here, and as we're growing new services, we really need to do a better job of kind of monitoring the market growth rate, and that again it gets related into financial performance as well. Quality, again, quality core measures, there are 33 last time I checked, quality measures in an accountable care organization quality reporting system. And those 11 of those 33, or a full 1/3, are more prevention and wellness oriented. So in that regard, we need to think larger than the traditional hospital compare scores or MB-QIP, which is designed specifically for critical access hospitals, and be thinking about these new quality measures. Even if we're not in an ACO, it really makes a lot of sense to start looking at the ACO measures and trying to prepare for them. Patient satisfaction scores, again, is HCAHPS. They are now directly tied into the financial formula, and so that one's pretty straightforward. Care management, really, we start to get into this kind of transitions of care. So it used to be that as hospitals, we were pretty much confined to the folks within our facility. And once they left, you know, it was always a good idea to have a safe handoff into other dimensions of care. But now, as we assume responsibility for the overall care of our patients, it's going to be vitally important to work with skilled nursing facilities, home health, durable medical costs, et cetera. And we didn't have to worry about what the long-term care costs were in the previous model, because that really wasn't our job. That was the long-term care industry's job. But we do now, and that means we need to be thinking about, I think, this whole question of aging services or how we help people age in place within their homes is extremely important. And so there are measures that, as we're looking, we need to look at where, if we're sending patients to a skilled nursing facility, what is the quality, what is the cost, and how do we factor that into our overall financial performance. And then we also need to think about the fact, is there a way that we can keep folks in their homes? Can we basically find some way to support them through technology, through, you know, caregivers? Community paramedics are kind of making a a big impact in many communities, and I know quite a number of hospitals have invested, community health workers, those sorts of things as well. And the second one there, behavioral and mental health screening rates are extremely important, because what we've discovered through our ACOs and the value models is that mental health and behavioral health has huge financial consequences. If we have patients that are pretty much frequent flyers in our emergency room, they're very costly, and in essence, dealing with mental health and maybe screening for mental health and behavioral health is going to prevent serious complications in the future, will reduce our emergency department usage, and just basically lower costs as well. And then again, there's such a correlation between behavioral and mental health and physical health that if we want to keep people healthy in a population health sense, we absolutely need to be mindful of and start to get measures on these behavioral health emergencies. So screening is one thing, and in these wellness visits, there's an extensive amount of mental health screening that goes on. For those of us that have public health backgrounds, public health picks up a huge significance here. And we need to know what are the county health rankings, the State Department of Health. They become partners. And we need to understand the diabetes rates, just the basic county health statistics, because, again, they become part of our financial formula. Second one, hierarchical condition coding is really very significant, because in essence, HCC codes, as they're called, indicate how sick our patients are. And in essence, because historically rural hospitals and rural providers have undercoded. In other words, folks are coming in, they're getting treated for one thing, but they may have, let's say they come in for the flu, but they also have diabetes. We're coding as if there's just the flu, and HCC codes then become extremely important, because if we start at point X with the health of a patient or a group of patients, and they seem to be relatively healthier than they are, then in essence, if we help to make them even healthier, the gap between where they are now and where we're trying to bring them becomes less, and it's just a part of a financial formula that's extremely important. So bottom line, hierarchical condition coding is extremely important in ACOs, and basically in terms of measuring the progress of populations and patients. Percent of primary care provider contracts containing population health activities. That one, again, we get back from what we know about the ACOs. We get back from our group of kind of key informants, our summit group, and also patient costs and other factors, time, travel, copay, deductible, lost wages. All of these are suggested as measures that we can start to think about and maybe build into our measurement system. Okay, here's kind of the organizational attributes is we're looking at tertiary care provider quality and cost scores. Again, as we're making referrals out of our rural community, we're sending them to tertiary care centers without much of a knowledge about how much those tertiary care services are costing or what the quality of those services are. And again, when we get access to data and information through these value models, we are able to determine where our referrals, what the cost and quality of those referral centers are, and we make wiser choices about where we send our patients. This is something that's been historic in the past. We just didn't know if we're a rural provider the quality and the cost of these tertiary care centers. And now we're going to have access to that, and we need to be tracking it. System affiliation as well. Are we doing better in our healthcare systems and under quality or not, et cetera? And this is one of those things where we don't have a viable measure at this point, but we think it's been suggested as being important. And then employed staff and providers versus independent or contracted. Does it make sense for us to employ the physicians, or does it not? What is the pros and cons, and where are the measures that we can look at in terms of advantages one way or the other? So with that, I am going to call on two of our participants. John Pantenberg is from the Stroudwater Group. Many of you know Stroudwater. He joined them in 2016. He's got a lot of experience in progressively responsible in terms of cost reductions, financial analysis, operation. Before joining Stroudwater, Jonathan served as Chief Financial Officer and Chief Operating Officer of the Kahuku Medical Center, which is a 21-bed critical access hospital on the North Shore of Oahu, Hawaii. So we especially appreciated John coming in. Was at least my first chance to work with John, and he represented Stroudwater, and he basically had some really kind of significant input. I'm also going to introduce Jack King, and Jack is somebody that I've known for years. He's with the Montana Flex program and the Montana Hospital Association. He's the director of the Rural Hospital Flexibility Program of Montana. He worked in rural healthcare for over 25 years. He's been a hospital trustee. He directed a network of 10 critical access hospitals, so he's got that experience. He's developed and directed a rural telehealth network, and he's directed the development of federal grants programs as well. So Jack kind of provided the State Hospital Association State Flex Program perspective, and John was one of several kind of financial consultants that kind of represented that community of expertise. So I'm going to call on John to begin with. And John, just, tell us a little bit about kind of why you were there, a little bit of perspective on why these new financial indicators are important, and anything else you'd like to share with the group.
Definitely, and thank you for inviting me. So as a part of the perspective, really why we were there was to look at how we can improve the overall performance of hospitals going forward. And what we wanted to look at, as Terry had mentioned, is both the lead and the lag indicators. When hospitals will generally assess organizations, it's usually from a financial perspective looking at historical information. And often it's difficult to try to make changes going forward because that information lags with availability. So with using these lead indicators, what we wanted to look at is, going forward, how can we merge ultimately quality and finance within an organization, realizing that quality is a large driver into the financial performance of an organization going forward. When looking at these indicators, what we also wanted to look at is, what are indicators that we can advertise to staff throughout the hospital that would be able to get their buy-in going forward? If you were to go to a nursing staff or your regular line departments, trying to tell them that we need to improve the total margin of an organization is not something that they can really buy into, or is it something they can realize the direct impact going forward. But what we wanted to talk about was, what are some of those indicators where they can impact the organizational care provided, which will impact the financial performance going forward. So an example of that is the patient satisfaction scores. This is something that we could regularly work on and set targets for our staff to try to achieve. And patient satisfaction is something that will directly impact reimbursements going forward. If we have poor patient satisfaction scores, people are less likely to use our services, or they're less likely to come back to the hospital. But by targeting these areas, it's an indirect way that we can improve the financial performance of an organization. And it's also a way that we can market that to our employees so that they buy into the initiatives that we're pushing forward.
And talk a little bit about how it's going to leverage reimbursement advantages, Jonathan. Any thoughts on that? Have you done a good bit of work with accountable care organizations over the years? Anything in particular you'd want to share there?
We've done different work with accountable care organizations. With looking at the designations, rural communities are in the position where they can leverage whether it's a health professional shortage area or a rural designation to try to qualify for a rural health clinic. It's leveraging these designations to try to improve reimbursements for the organization as a whole. What we don't want to do is continue with the prior or the status quo for reimbursement and assume that our only advantage is to get cost-based reimbursement under the critical access hospital model. We want to really leverage all those advantages that are available to us in rural communities to really maximize resources available to the hospital, but also to increase the access to care within the communities. And a lot of these designations, what we've seen is critical access hospitals that have leveraged rural health clinics have been able to add other medical or surgical specialties into the communities, or they've been able to increase access to care. It's really using the advantages available to critical access hospitals to increase service delivery. From an ACO perspective, it's really collaborating with your other partners within the community and really looking at the total cost of care and the care spectrum. It's working to reduce redundancies and working to reduce overall cost. That's really the goal from a perspective. By reducing that overall cost, it will benefit you in the ACO world, but it'll also directly benefit you by decreasing your overall cost to the organization itself.
Jonathan, when you go in and you're talking to hospitals, perhaps you could give us kind of a specific example about indicators that you are suggesting, perhaps some of the ones that we've identified here, that you are suggesting that they be monitoring. So could you give us like a real-life case, and you don't have to name the hospital itself, but what sort of things are you as a consulting organization suggesting that these hospitals monitor?
Definitely. So we were working with a hospital out in Colorado, and they were looking at trying to expand their primary care presence. So some of the ratios that we had really looked at, or some of the ones we identified in here, was looking at the patient panel size for an individual physician, also with looking at the productivity requirements for the individual physician. So we wanted to make sure that those physicians were maximizing their time and also seeing the patients appropriate based on the number of providers they had. What we didn't want to do was we didn't want to have them expand the number of physicians if there were underlying operational inefficiencies there that were preventing them from seeing the maximum number of patients. So it was looking more at, like we were talking about earlier, is those operational efficiencies to ensure that we're spending our dollars effectively within a region.
Mm-hmm. Thank you. I'm going to turn to Jack, and I may have a follow-up question for you, Jonathan, so hang on there. Jack, talk to us a little bit about, again, kind of your experience at the summit, a little bit about, kind of why you see this as important for flex programs, the Medicare flex programs, and for hospital associations, et cetera. So I'm going to have Jack talk for a while here. Jack?
Oh, hi, Terry.
Hi.
I'm tickled to be involved here, and it's kind of funny you asking about why I was at the summit. I was tickled to be invited, but never did really truly understand why I was there, because I'm not especially known for my financial acumen. But I certainly enjoyed the conversation and the process, and have certainly recognized the value of the work and identifying the additional number of financial indicators, the lead indicators that I think are becoming extremely important. And what I'm going to come down on here initially is, John talked about it, and you've talked about the importance of getting our staffs to understand, our hospital staffs to understand certain indicators and be able to use indicators as goals. and how important that is, but I'm going to extend that to our governing boards. Within the rural frontier world, most of essentially all of our critical access hospitals and small hospitals are still not-for-profit organizations, which means they're governed by local volunteer, in most cases volunteer boards. And having started my healthcare career as a board member, you cannot overestimate the importance and the value of putting absolutely as much education as you can in the hands of our boards. And so, since most of our community leaders and board types come out of business, the local business community and the agricultural community, their comfort with the traditional financial indicators, is pretty good. If you can put what is now the old CAH Finance 101 in their hands, they can grasp that pretty quickly and be able to go through a dashboard and be able to see financially how the organization is doing. But what we did at the summit was put another layer of indicators that extends out outside the walls of the hospital and the organization into the community and elsewhere. And I think it's going to be really, really important going forward that we add the evaluation and the discussion about those indicators at the board table. Things like, the market indicators, extremely important. And, increased focus on quality and safety. And John mentioned that. Again, with most of our board members coming out of the financial world, I think, we need to be very sure that we have our boards understand their incredible role in quality and patient safety going forward. Community health, as our small hospitals, frontier hospitals, become accountable, if you would, for the population health of their community, it's really important that our board members who are coming from that community, interacting with that community, have a pretty good understanding of what kinds of indicators are out there that would determine how the organization can do going forward and what they need to do for their communities going forward. Organizational attributes, I'll pick on one here, system affiliation. If the organization is even going to consider affiliation, the board needs to have a really, really clear understanding of what they bring to the table and what that affiliation may bring to them and their community. These are challenging times coming forward for healthcare, and not one bit less for our governing boards.
Yeah, and kind of picking up on that, Jack, in essence, this movement into value and population health is going to require an investment, and a non-traditional investment, and it's vitally important that rural boards understand kind of the critical path, to survival and doing well in this different payment system. And I really do applaud your focus on providing support in that area, because again, two of the biggest issues that we're identifying now here are providers that don't understand, or providers who aren't working in full collaboration with hospitals. And the second one, I think, is boards that just really don't understand kind of what is happening. And at worst, boards can micromanage the finances to the point where a leader who's trying to move that hospital into the future gets stymied by a board that just can't understand that it's a new day and that there are new measures that can be here as well. Jack, I know you're interested, and again, as we have measures, and again, we don't want to throw, it's like measures out with a fire hose, but we are suggesting that some of these new measures be factored into either a dashboard or a balanced scorecard, et cetera. Can you talk a little bit about why Montana might be interested in either balanced scorecard or incorporating some of these measures into a dashboard?
Oh, sure, and I remember specifically the conversation that you and I and John had at the summit about this. Montana may be a little unique in the CAH world. We have 48 critical access hospitals, 17 of them are considered by the Flex monitoring team to be what they call FAR hospitals, frontier and remote. And so the sustainability, survivability of these organizations is just, well, it's just really, really important. And as you've heard me say before, when we close a rural or frontier hospital, then we got people out there that are going to start dying from things that people in other areas don't die from, and that we just can't do that. And you and I had talked about developing a balanced scorecard that included, many of these new indicators that were, possibly specific to those frontier and remote hospitals that they need to have a firm handle on going forward. And so, you take the 101 measures, and that can be certainly one kind of indicator. But I'm hoping that you and I and some others can get together and start working on a balanced scorecard that points a bigger picture, that allows a board to easily or more comprehensively understand what's going on in their organization, and more importantly, what they're going to need to do going forward to survive for their community.
Yeah, that's very well said, Jack. Thank you. The question we have up there right now is, what resources could state flex programs, rural hospital programs, rural health networks provide to better support rural hospitals so they can successfully implement these key financial strategies? And Jack, I think you've already mentioned some of those in terms of some training and education, perhaps balanced scorecard, et cetera. But let me turn to Jonathan, and any thoughts on this, Jonathan? And I'm wondering also about assistance in developing some benchmarks here as we move forward. So, for example, on days in accounts receivable, we have benchmarks. We know what the mean is and what the average is for rural or critical access hospitals across the country. But in some of these other ones, frankly, we're kind of stumped as to where are the measures or how can we find them, et cetera. So I'm just wondering, anything that you could share on that, Jonathan? My assumption would be that as a consulting organization of financial expertise, that you may have access to some of this information that might be shared with others or shared with us.
Yeah, there is information available. I think that it's also important that where the state flex and rural hospital programs can really step in is giving these hospitals the ability to collaborate with each other. When looking at hospital, in my prior time as working on the hospital operations side, when you're working in the day-to-day of a hospital, you're going from problem to problem, and you really don't have a great amount of time to sit there and look at how can we truly make changes and who maybe has done what we're trying to do before. So I think that that's one resource that the different state agencies can provide, is really a way for hospitals to try to collaborate and look at improving the organization as a whole. And I think also just leveraging data, and maybe the state flex coordinators or the state flex programs or the rural hospital programs can kind of serve as a conduit for some of that data going forward. And the data is available. I think that where the different programs can help is how to parse through and leverage that data to really try to make performance improvements going forward. And like you're saying, is to come up with those benchmarks, but then also come up with how the organizations can try to achieve some of those benchmarks. It's one thing to just say what they should try to do, but I think the big gap is in how to actually get to achieving those benchmarks themselves.
Right, and as these accountable care organizations are moving forward, they can benchmark against each other. So if you've got 8 hospitals in an accountable care organization, all 8 of them could be collecting information, not only to benchmark themselves in terms of improvement, but also, across the ACO, or it could be done at the state level too, through a flex program or state hospital association, et cetera.
Exactly.
So, well, I appreciate it, guys. Thank you so much for participating and for your perspectives. We think this is going to be a valuable set of indicators, and as I indicated, we're going to continue to kind of monitor the measurements and to make sure that we're getting all the information we can out there. So the next one is, these are some key performance indicator resources, and I just recommend these very, very strongly. So the 2017 Rural Hospital Value-Based Strategic Summit, all of these are available on our ruralcenter.org website. The Balanced Scorecard and Strategy Map templates, the information from the Flex Monitoring Team. Those of you who may not know what this is, it's the 3 universities, University of Minnesota, University of Southern Maine, and the University of North Carolina, financial quality, and just various EMS, various other types of information. They are a great resource. We have a transition toolkit on financial and operational strategies. Again, this is all provided through funding from the Federal Office of Rural Health Policy. And again, we get the best people we can find in the country to put these toolkits together. And as I indicated, also hold these summit meetings at least on an annual basis. There's a quality improvement implementation guide and toolkit for cause. Rural Health Value, which is out of the University of Iowa, led by Keith Mueller and Dr. Clint McKinney, are another great resource. If you haven't gone to that website, please do. We saw they just issued a new report on rural accountable care organizations. We host a population health portal, which gets into, if you come into our site and go through that population health portal, we have a readiness assessment in there. It basically contains lots of data and information for virtually every county in the country, and so we recommend that to you. Rural Health Information Hub, RHI Hub, which is out of the University of North Dakota, has a variety of different, they're another partner of ours, and they're more of the Rural Health Library. Now, we have updated a manual, the COP Finance 101 Guide Updates. First of all, and let's leave it in the past, the name has changed. It's now the Small Rural Hospital and Clinic Finance Guide. The previous guide, I think, was our most downloaded resource from the center, and we have so many resources here. It's been, we think, really valuable, and now it's better. It's got new data in there, new numbers, so check that out. The 2012 Key Indicator Review is in it, and also it incorporated the 2018 Key Indicators for Rural Hospitals and Clinics as well. So Ralph Llewellyn was the person we worked with from the Eide Bailey firm, and we think Ralph did a great job, and very importantly, Ralph's really excited about it as well. He highly recommends it to you, and we do as well. Over 20 pages of new material, particularly looking at the rural health clinic information. So 3 provider sections, one on critical access hospitals, another section on just small rural hospitals, and then, as I indicated, the rural health clinic section as well. Additional performance indicators and strategies. They've got a list there: market share, financial, operational efficiency, workforce, care management, quality performance, community health, and then kind of overarching strategies as well. So that's all a part of that Finance 101 annual, and we do recommend it to you. With that, I'm going to send it back. Again, thanks again to our speakers, but I'm going to send it back to Sally, who's going to finish this presentation.
And the next slide is just a screenshot of the Finance 101 manual, and that's up on the website for the center, and we've indicated a few of the key topics there. And this is our most heavily used resource on the center website. Of 1,000 different resources and webinar recordings, the Finance 101 manual, and that's why it was good to update it from 2012 because the healthcare market has changed, and then also we were asked by SRHT to expand it to all small rural hospitals and rural health clinics as well, and is a great resource for critical access hospitals, small rural hospitals with their board of directors and with new staff as well. Then the other resource we'd like to share, of course, is the summit report that we covered today in the webinar, and there is a one-page summary as well on that to share with staff, providers, and board members. And then just a final reminder for Small Rural Hospital Transitions Project is we're coming up to a new application period, and there are 180 eligible small rural hospitals in 21 different states because it needs to be a hospital 49 beds or less in an area of persistent poverty, and be hospitals who are at a position to undertake an on-site consultation and work with our team and consultants on action planning to implement recommendations and participate in the learning collaborative following the consultation. But again, the key is assisting hospitals in that transition to value-based care and payment models. So the application site opens on September 26th. However, the website gives quite a bit, it gives the questions and how to prepare for the application. So we encourage you to look at that with their leadership team. We have reached out to the 180 eligible hospitals and state partners in preparation, but we're happy to take any questions about that. So just a reminder to prepare for the application if you are an eligible hospital or hospitals in your network or in your state. So just to close, let us be your resource center. We encourage you to visit the Center for Webinar Recordings and the manual and report that we referenced today. Are there any questions? We can take those in the chat box. No, we have a closing assessment that will be posted, so please take a few moments before you log off to provide your feedback to the short online assessment. And also, if you are looking to request the ACHE qualified credit, we'll need you to complete the assessment and provide us your email address. So thank you for joining today's webinar. Have a great day.
Thanks, everyone.